Okay, start.
Okay. Yes.
While starting with the bioresorbable scaffolds, the first thing whenever we thought of think of in any artery, we should think of two things. One is if there is an eccentric plaque, when there is an eccentric plaque, the vessel will be reacts in two ways. One is of a positive remodeling, and there is of a negative remodeling. The positive remodeling is known as Glasgow effect. So what is a Glasgow effect means whenever there is a plaque burden is increasing, so the media will go in an expansion phase so that it accommodates the plaque and the vessel will expand. This is of a Glasgow effect. Next is of a negative remodeling. In spite of the plaque burden, like for example, the negative in negative remodeling, what will happen? Like whenever the plaque burden is increasing, the media will go into a spasm which is of a negative remodeling. So why these phenomena are important? Because the introduction of a balloon angioplasty in the beginning of a plaque, which was causing a reflex of vasospasm because of the negative remodeling effect. Whenever you do a balloon angioplasty, despite the same plaque burden, the lumen will narrow because of the pressure given by the balloon. There is a reflex vasospasm of the media. This is known as negative remodeling. So whatever the stunt which of a scaffold or a metal will prevent this media to get a spasm and obstruct that part of a negative remodeling and maintain the vessel patency. So this is the thing of an intervention of a from the generation of a stunt scaffolds, whatever they have invented. The first thing of a balloon angioplasty introduction was a transformation moment in the cardiovascular medicine. But the balloon angioplasty made the things worse by the reflex vasospasm, which is of a negative remodeling effect. So to stabilize it, then they have introduced of a metallic stent, which has solved the major drawback by the balloon angioplasty by reflecting this negative remodeling. And in the early days, is different of an acute and subacute closure and negative remodeling by the metallic stents. However, restenosis due to the new intimal proliferation remains a troublesome for the bare metal stent in future. So in the long term. So to prevent this, the next generation came of a drug-eluting stents, which were reduced to half despite of these improvements. There is specific concern of in a very late stage thrombosis compared to the first generation this. So whatever the thing is, the first balloon angioplasty is whatever they used in first, they have a more effect on the negative remodeling effect. To prevent the negative remodeling, they introduced of a bare metal stents. From the bare metal stents, they come to drug eluting to prevent the late stent thrombosis. From the first generation to the second generation drug eluting to prevent these very late and very late stent thrombosis. And now the adoption of a thinner polymer clots or a thinner stents, new drugs second improved the target vessel revascularization and stent thrombosis. And now comes the new generation of a bioresorbable scaffolds to prevent the further thing of advantages of the scaffolds. There are some delimitation of your drug eluting stunts. To prevent it, they've introduced the bioresorbable scaffolds. So when you see this diagram, this is of a drug eluting stunt. There will be of a stunt platform and a delivery system and a drug carrier of a polymer surface modification, and there will be a pharmacological agent to prevent the endothelialization, which is of a slow releasing drug. So these are the three components of a drug eluting stunt. So what was the problem with this drug metallic process with a long-term disadvantage? Why they want to invent a bioresorbable scaffold? The first thing what is restricting the physiological vasomotion by the metal, and it's adapting the arterial remodeling, which will be difficult with the metallic processes of the outside layer. And in case of a future bypass grafting, the suture stay will not be on the will not be taken easily from the graft from the native vessel because of the stunt. And the polymer gives in a chronic foreign body reaction. This is one of the long-term disadvantages with the metallic processes. Next, Because of the scaffolds, sometimes there will be neoarthrosis, incomplete endothelialization, and very late stent thrombosis is one of the possibility. And second, because of this metal, there is a permanent side branch jailing. And to see the non-invasive imaging like a CT and MRI to visualize the vessel, to prevent this, the metal will make an obscuring of the image. So to prevent this, they have discovered bioresorbable scaffolds. అర్థమైందరా?
Yes, yes.
So to prevent these things, these are the 5, 6 indications as of now for the innovation of these bioresorbable scaffolds. One is restoring the physiological vasomotion, impeding of a future bypass graft, and if a chronic foreign body reaction to the polymer, and neoatherosclerosis because of incomplete endothelialization and very late stent thrombus can be prevented, and permanent side branch gelling by the metal, and which was an opaque to CT and MRI by the things metallic. So an optimal bioresource scaffold should have provide both short-term and mid-term scaffolding of the diseased artery, not to get vasospasm, the negative remodeling effect, and it should provide sufficient radial strength to avoid recoil, should have the ability to completely dissolve, should be the biocompatible absorbed material. It should be delivered easily and flexible because there will be no metal, the tracking will be very difficult, and it should have a reliable absorption over a definite period. So considering these two major sources, currently there are two things. The one is the bioabsorbable polymers like polylactic acid, polyglycolic acid, polyprolactone, tyrosine derived polycarbonates. Whereas corrodable metal-based alloys like in magnesium and iron, when magnesium was made an alloy, this will be reacted with your water in your blood and it will be metabolized to magnesium oxide and it will be nullified in the same way with the iron alloys. So these are the things. So the scaffolds, the generation, how it takes us, the story so far is Igaki Tamai, the first device of its kind was a polylactic acid with no anti-proliferative drug system. This system was a self-expanding, and they used to deliver this non-proliferating drug, polylactic acid, by the observed stern. And with the post dilation, the second balloon was post dilation balloonation. They needed to need with the balloon is dilated with a contrast heated up to 70 to 80 degrees Celsius. But this was abscond because of the heated contrast. The next trials, the follow-up is the observed bioresorbable vascular scaffolds. So the observed scaffold consists of a semi-crystalline polylactic backbone coated with a poly-D-lactic acid with a strut thickness of 157 microns. So they have done an observed cohort A and cohort B trials. They were non-inferior. Moreover, the rate of cardiac remains unchanged after 5 years. It's just like a normal humans, normal individuals with risk factors. Where observed cohort B studied just second generation bio, which was modified to increase the scaffold integrity. And with this study, they have a major adverse cardiac events were high in this study. So next, there are observed 2 and 3 trials. They compared these bioreferral scaffolds with the Zines primary endpoints where there is a superior for angiographic vasomotion and there are non-inferior of late lumen loss. Neither of these endpoints meted 3-year follow-up. The incidence of scaffold thrombus after 3 years was significantly higher in bioreferral scaffold group. So these are the trials first of the bioreferral scaffold. So the lessons learned from this observed study are there are more often there are 3 mechanisms for the scaffolds. Four mechanisms for the scaffold failure. One is device-related mechanics, another is the patient-related mechanics, and third is the lesion-related factors, and fourth is the procedure. So the device-related mechanics. So the device-related mechanics are because of the thick struts of the bioscaffolds, the endotheliation is not going well. This is the first thing. Because of the reduced radial strength and tensile strength, and another thing is the struts producing into the vessel lumen, the shear stress and axillary thrombus is high with these bioscaffolds. And the most important phenomenon, device-related mechanics is dismantling phenomena. Because of the loss of the structural integrity during the resorption phase of scaffold, this This scaffold resorption phase structure, like I'll show this image. So in this first image, you can see the scaffold is of a discontinuity, just like an stunt fracture, which makes the endothelialization non-uniform and scaffold thrombus are more. So this is the scaffold. One of this phenomenon is known as dismantling phenomena, which is of a loss of structural integrity. The scaffolds has to be uniform over the vessel intima so that the endothelialization will be a uniform phenomena, not like irregular phenomena, which may predispose to the needles for the thrombus. అర్థమైందరా? హలో,
కంటిన్యూ.
Yes.
నిద్రపోయాడు సమరగాడు? ఓకే, హలో. The next second is the patient related factors. In scaffold should be avoided in whoever the patient with a chronic inflammation like CKD, any advanced age, reduced EF, CKD, advanced age, uh,
Oh, yes.
and reduced ejection fraction, and smoking. In these patients, these scaffolds will have a high risk of a thrombosis. In second, in spite of acute coronary syndrome is a soft plaque, in putting a scaffolds are bioresorbable scaffolds are too risky because of the high thrombus burden. And vasoconstriction, because of the vasoconstriction, vessel size mismatch will be more with scaffolds. They don't have a radial strength to expand along. So, and third is the patient led with DAPT. DAPT discontinued during first year after bioresorbable implantation also with significantly increase of MI and scaffold thrombosis. The current study says that 12 months of DAPT should be used for the post-implantation. And lesion-related factors. In the observed trial 2 and 3, they have mentioned clearly that this is 2.2 mm vessel size. There is a high risk of scaffold thrombosis. And it should not be used in of any bifurcation lesions, calcified lesions, and osteal lesions because of the suboptimal opposition. And in longer lesions, it should be avoided. So next is the procedure.
Bioresorbable stent is not FDA approved yet, na?
Not approved. There is one study is going on. I think Mary's film trial. It's under this is till 1 year trial was ongoing. So the thing is, whenever you think of a scaffold, the lesion should be straightforward, and it should not be of a high thrombus nor calcium, and it should be not a lengthy lesion, and the trackability should be good. The vessel should not be a tortuous vessel. Hello, in this now.
Okay. Yeah.
So next, what is the procedure related? During a procedure, the adequate aggressive pre-dilatation should be done, which usually 1:1 sized balloon, and supplementary tools like cutting or the calcium should be completely debulked should be done. Otherwise, the stunt dislodgement will be high. First. Second, this is a PSP technique. Second, appropriate sizing of the bioresorbable scaffold by using an imaging study to definitely see the approximate size. Third is the post dilatation, using of a non-compliant balloon sized up to 0.5 above the nominal diameter should be used, not with the distal diameter. This is the PSP technique. Pre-dilatation, sizing, and post-dilatation should be done to prevent the scaffold thrombosis. Hello.
Okay.
So these are the drugs. These are the generation of the bioresorbable scaffolds till now. What I mentioned first was is the observed beavers. After that, there is a dissolve and ART pure and Magmarus, Phantom, and Meris 100. In all these, the strut thickness of an average of 150 microns. Till now, with a less strut thickness of a Meris 100 microns is the only strut thickness of 100 microns, which is of a less in biorefer scaffolds. And the resorption time is 2 years. There are some studies saying that till 2 years, DAPT should be continued to prevent the scaffold things. But whatever the thing, the current studies is including the positive trial says that 1 year of DAPT is more enough for them. Hello.
Okay.
Hello, Nitin.
Okay. Continue.
So these are the generation of the stunts. There are different classification. This is from Grossman. In Topol, there are, which is the first generation. If you see, this is cipher taxes. This is like the polymer. If you can see, as the generation increases, the polymer, the occupying the space of the stunt, it is getting reduced. There, as you can see, this is the first generation. Second is the our second generation, like a Resolute, Zynes, and Promus, and Resolute Onyx. Second is a biodegradable polymer in Biomatrix. And as you come to Orsiro, Synergy, and Ultimaster, they will have a polymer which is of very less, but coming to the biofreedom and drug polymer free stunts. So in this, they have usually mentioned in Topolis first generation, second generation. This is 3A, 3B, sorry, 3B, sorry, కనిపిస్తుందా?
త్రీ ఏ 3B ఏంటి?
యాక్చువల్ గా మన దీంట్లో ఏం చూపించాడంటే టోపోల్లో జనరల్
జనరేషన్
మనం స్టంట్స్ జనరేషన్ ఫస్ట్ జనరేషన్ సెకండ్ జనరేషన్ లోనే ఇందులో క్యాల్కులేట్ కాకపోతే బయోడిగ్రేడబుల్ పాలిమర్స్ అనేవి 3A 3B చేశాడు.
ఓకే
ఓకేనా? సో నెక్స్ట్ ఈస్ ద
బయోడిగ్రేడబుల్ పాలిమర్స్
బయోడిగ్రేడబుల్ పాలిమర్ క్లాస్ 3A 3B అన్నమాట.
ఓకే.
నువ్వు చూస్తున్న కొద్దీ ద పాలిమర్ కంటెంట్ అనేది ప్రతి స్టంట్ లో తగ్గిపోతూ వస్తుంది. సో ద ఫస్ట్ స్టంట్ ఆఫ్ బయోడిగ్రేడబుల్ పాలిమర్ ఇస్ బయోఫ్రీడమ్. మనం బయోమెట్రిక్స్ అని వాడతాం చూసా. దీస్ పాలిమర్స్ విల్ డిగ్రేడ్. Next is your this down is your bioscaffolds, which is of a first generation and second generation. If you, as I mentioned, observe bioscaffolds, which is of a polylactic acid. And as the generation advances, they use of a magnesium alloys and the what you say tyrosine polycarbonate and iron alloys. These are the recent ones. Hello, వినిపిస్తుందా? Okay, so these are the generation of the stunts of a bioscaffolds and our first generation, second generation, 3A 3B and scaffold first and second. So from here you can see of a different things. The first is of a scaffold discontinuity, which is resembles to a stunt fracture. Second is of the dismantling phenomena. Second is your malopposition, because the scaffolds are uniform, not an uniform thing like a metal visual not there. Malopposition is of a high risk. That's what he said. Now the plaque, it should be well prepared, like a curtain balloon. Everything should be done to prepare the plaque. Then only the scaffolds will attach to the intima easily. Otherwise, malopposition will be a big thing. Next, if the opposition was not good, future neoatherosclerosis have high risk. And second thing, if the scaffolds are not regularly paced, there is a nidus formation of more thrombus. Okay.
Okay.
So this is under expansion, because if you don't dilate a post dilate balloon, అది చూపేది కదా selection ఉంది కదా PSP, pre-dilatation, selection and post-dilatation, 0.5 mm with the neo-intimal vessel. Otherwise, the under expansion will be the high with this one, because the way how the scaffolds will dilate is entirely different from a normal drug-eluting metallic stent. Okay. Next, edge-related progression is also more with scaffolds. So this is the recent trial of a Meris 100 biodescribable score. That's a FIM trial. The FIM trial is of aim to assess the intermediate term safety of a novel ultra thin stud sirolimus eluting iron bioresorbable scaffold in non-complex coronary lesions. In this first human experience, the ultra thin bioscaffold was safe and effective for the treatment of de novo non-complex coronary up to 3-year follow-up.
But Merrill was PLLA. It's iron. In that chart, last Merrill shown content
There
made
is-
up of P
There is 100
PLLM. means
compare-
different, is different.
ఏంటండి
But in last 3 slide back, you shown one diagram, no, means table. In Mary's last column, Mary's stent, it is made up of PLLA. But in this trial, it's showing it's made up of iron. Ultra strut sirolimus
Actually,
eluting
what they
iron.
said is in film trailer they did an ultra thin struts eluting iron stunt kada. So with them, the Merrill people has commenced a program of randomized control trial with worldwide participation. They included in this trial. Till now, in this film trial, it's an ongoing trial. ఇంకా ఇది ఎక్స్టెండ్ అయింది ఇప్పుడు. ఫస్ట్ వచ్చి ఈ ఫిల్మ్ ట్రయల్ అనేది ఇంతవరకు మనం మెరిస్తున్న ట్రయల్ ఏది లేదురా ఇండియాలో.
Okay.
ఆల్రెడీ ఉన్న ట్రయల్ నే ఎక్స్టెండ్ చేశారు. వాళ్ళు ఇక్కడ ఏం చెప్పారంటే అప్డేట్ లో, based on the increase in resulting of the film trial, Merrill Life Sciences has recommended a program of randomized control trial with a worldwide participation, which include Merrill's Extend and Merrill's 100 China trials. A pivotal randomized control of Merrill versus Zines. ఈ ట్రయల్ లో ఇంక్లూడ్ చేశారు వాళ్ళ దాంట్లో. ఇది ఆన్గోయింగ్ ట్రయల్, ఇది ఫిల్మ్ ట్రయల్. నెక్స్ట్ రీసెంట్ వన్ వాజ్ దిస్ బయోమ్యాక్ కదరా. So what this was, what I mentioned is before we mentioned this one Magmaris. So this is of a Magmaris of the scaffolds will be made of magnesium. Once they react in your body, they will be oxidized into magnesium oxide and the scaffolds will disintegrate. So they are comparing of a Magmaris with a computed coronary computed tomography. See the diagnostic accuracy of for coronary arteries. What they said is magnesium-based bioresorbable stents secure acute PCI results without follow-up implant is fully interruptible, and we confirm the long-term safety profile, leaving long-term metallic casing effect. Metal అనేది complete గా resolve ఉందంట వీళ్ళ CCTG. This was the recent trials. Hello.
Okay.
So next is another iron-based trial is the film trial. Magnesium iron చెప్పాను కదా, iron alloy based bioresorbable is the film trial.
Okay.
Okay, finish.
So bios అయిపోయింది.